Thank you all very much. Before we begin with the public comment session, I understand that Dr. Sanchez has joined us. Dr. Sanchez, if you are there, could you please state your affiliation and any conflicts of interest?
Dr. Romero, this is Pablo Sanchez. I'm a professor of pediatrics at Nationwide Children's and Ohio State University in Columbus, and I have no conflicts. Thank you.
Thank you for joining us. So I'll now move on to the public comment session. Let me begin by saying that I want to welcome all those that will be giving public comment today, and thank you for your dedication to this process. The committee views your comments as important and takes them into consideration. All speakers today submitted a request in advance of the meeting, and the final list of commenters was determined via a lottery. For the speakers, it's very important that we note that there is a limited public comment period, and in order to make it through the entire period and all speakers, it's important that you maintain yourself within the limits or time frame allotted to each of you. Each of you has been allotted 3 minutes. There will be a timer displayed on the screen that will cycle through different colors. As you reach your time limit, I will state, thank you for your comment, your time has expired. If you exceed that by 15 seconds, I will state, as a courtesy to other speakers, we ask that you conclude your comment. And if you extend yourself to 30 seconds beyond your allotted time, your microphone will be cut, and I will say, your comment time has ended, thank you. So again, we thank you very much for the time you're going to spend with us and your comments. And let me begin with our first speaker, Dr. Larry Saltzman, please.
Thank you for the opportunity to speak to you today. I am Dr. Larry Saltzman, a board-certified family physician, the Executive Research Director for the Leukemia and Lymphoma Society, and a blood cancer survivor now for over 11 years. I am here today to urge CDC to implement a COVID-19 vaccine booster program. We need a large-scale nationwide clinical trial to assess their safety and effectiveness. As a family physician, I emphasize preventative medicine, including immunizations for all. In my career, I have seen cases of tetanus, measles, and other diseases that are now preventable. In October of 2009, I self-diagnosed my lymphoma, confirmed as atypical chronic lymphocytic leukemia and small cell lymphocytic lymphoma. I've been treated on multiple occasions, including chemotherapy, the removal of the right side of my colon due to lymphoma blockage, and years of oral targeted anti-cancer drugs. My most recent relapse was quite severe. From October 2019 through January 2020, I was hospitalized on 5 separate occasions and treated with 3 different courses of chemotherapy. The culmination of these treatments was CAR-T immunotherapy, where my white blood cells were genetically reprogrammed and reinfused so they could act as little Pac-Men, hunting down and destroying my blood cancer. As I returned home in February 2020, I was looking forward to recovery and normal activities until SARS-CoV-2 essentially shut down the world and created a very hostile environment for me and all blood cancer patients to live in. A 2021 publication in Nature Medicine by Bengi found mortality rates as high as 55% among patients with COVID-19 who also have hematologic cancer. Severe COVID-19 infection is preventable with the available vaccines. I received the COVID-19 mRNA vaccines in January and February 2021. However, I made no detectable antibodies to the spike protein. Based on an ongoing study by the Leukemia and Lymphoma Society published online today in Cancer Cell, we estimate 25% of blood cancer patients, or 250,000 in the USA, did not have an antibody response to the vaccine. There are an estimated to be 5 million immunocompromised patients at risk in America, including any condition that requires chemotherapy or immune suppressive treatments. We have been advised by the CDC that masks are no longer recommended in most settings. Patients like me are left in the lurch. I am in quarantine. I do not trust all unmasked to be vaccinated. I'm hearing too many stories of immunocompromised people like me who are taking matters into their own hands. Thank you for your time and consideration.
Thank you for your comment. Our next speaker is Thayer Phillips. Excuse me if I mispronounced your name.
That's fine.
Thank you. Go ahead, please.
Good afternoon. My name is Thayer Phillips of Seniors Speak Out. For the 20 years before I became eligible for Medicare and the 8 years since, I have been an advocate for the concerns of older Americans. It is important to remember that well before COVID, pneumococcal diseases were a serious threat to seniors. We know that as we grow older, our protective immune responses are weakened, and that increases our vulnerability to infectious diseases such as pneumonia. Each year, about 1.3 million people visit emergency departments with pneumonia, and nearly 50,000 people will die from it, many of whom are older Americans. That has not changed and will continue to be our reality post-pandemic. In fact, there is perhaps good reason to be concerned that post-COVID, we may be even more at risk due to lung damage among COVID survivors, deferred medical care for comorbidities, and an increased sedentary lifestyle during pandemic-driven quarantine. I know that this committee has enormous issues before it, but it is a matter of life and death to many seniors who rightfully want to do everything they can to protect themselves as this first post-pandemic flu and pneumonia season approaches. 80% of the deaths during the pandemic were older Americans over the age of 65. We can't let them again bear so heavy a burden. We, and by that I mean we older Americans, lead the country in protecting ourselves from COVID, as those 65 and older have the highest rate of vaccination among all age groups, with 89% having received at least one dose, compared with 68% for people ages 18 to 64. We understand the risks, and we can and do make carefully thought out decisions to protect ourselves. What we need is access as quickly as possible to preventive measures that make a difference. There are now 2 FDA-approved vaccines that offer greater protection against pneumonia. We need your help in making them available to us now. This fall, as the normal vaccination period begins, and with a threat of an intense flu season, seniors will need every tool available to keep themselves healthy. It would be disappointing if the availability of these new medicines was hindered in any way. As shown during COVID, we know that when necessary, this committee can move quickly. I think this is one of those times that require prompt attention. Every scientific advancement in vaccine saves lives. So I urge the committee to expedite the review and approval of these new vaccines to further empower our generation with the medicines we need to protect ourselves. Thank you.
Thank you for your comments. Our next speaker is Mr. Robert Nukin.
I am Robert Mnuchin, a law professor at Harvard. Last December, because I had end-stage kidney disease, my daughter Jennifer Mnuchin lovingly donated a kidney for me at UCLA. Her kidney was flown on the red eye to Boston and was transplanted into me at Mass General. The good news is my kidney function is now in the normal range. The bad news is that the powerful immunosuppressant drugs I take to prevent organ rejection make me not only more susceptible to infections of all kinds, including COVID-19, but less likely to be protected by the standard vaccination protocol. Like many transplant recipients, my 2 shots of Pfizer provided me with no antibody protection against COVID-19. A spike antibody test shows my antibody level at 0, completely undetectable. I know, and you know, that an additional shot might provide life-saving protection for people like me with little risk. Yet I and people in my position currently can't get authorized access to a 3rd shot, even if our physician's clinical judgment favors it. In the broader debate concerning the wisdom of boosters for the general population, your committee must persuade the CDC to stop ignoring the critical special needs of organ transplant patients and others who are immunocompromised, and allow access to a third shot now. My situation is not unusual. A Johns Hopkins study of transplant recipients and other immunocompromised individuals showed that nearly half had no immune response to their vaccines. A third shot would likely make a meaningful difference for many of us. A French study reported in the New England Journal of Medicine showed that among the 59 patients who lacked antibody response after 2 shots, 44%, nearly half, developed antibodies with the third shot, with no serious adverse events. An observational study from Johns Hopkins had similar results. Other nations, France, Israel, and Great Britain, are taking action now to promote boosters for transplant recipients and the immunocompromised. And yet, when I asked my doctors about getting a third shot, they told me that they currently lacked any authority to recommend it or provide access. I understand how dangerous COVID could be for me. An Israeli study showed that 40% of severe vaccine breakthrough cases in the hospital were among immunocompromised people. And the Delta variant is making this situation worse. As breakthrough cases become more common, people like me aren't protected, even if we carefully limit our interaction to vaccinated people. This situation needs to change. Your committee must tell the CDC not to ignore the special needs of immunized compromised people. Please show the leadership and the compassion necessary to recognize the scientific and moral imperative.
Thank you for your
allowing
comment.
the third
Time has
shot
expired.
for this group now. Encourage the CDC to follow the French, Israelis, and British examples and explicitly recommend that the United States permit a booster for this population. Thank you.
Thank you for your comment. Our next speaker is Mr. Mark Gibbons.
Good afternoon. This is Mark Gibbons. I'm President and CEO of Retire Safe. Thank you, committee, for allowing me to speak. Retire Safe is an organization whose mission is to educate and advocate on behalf of older Americans on issues including Social Security, Medicare, health, safe retirement, and financial well-being. Currently, there are nearly 70 million Americans over the age of 60. Due to immune system decline as part of aging, as well as the prevalence of chronic disease comorbidities, many of them are particularly vulnerable to infectious disease such as influenza, pneumococcal pneumonia, and of course, COVID-19. Vaccines for these and other conditions can truly be a matter of life or death, and we are grateful for the continued work by ACIP to evaluate and approve critical vaccines for COVID-19. While we are encouraged by the progress made towards vaccinating older Americans against COVID-19, we are increasingly concerned that experts are predicting that the flu and pneumonia season to be more serious than last year. Now the states across the country are relaxing COVID-19 restrictions. In the U.S., it is estimated that more than 150,000 hospitalizations from pneumococcal pneumonia occur each year, and about 5 to 7% of those who are hospitalized from it will die. The death rate is even higher in those aged 65 years and older due to the strength of the body's immune system declining over time. Given this increased vulnerability, and in light of encouraging news that the FDA has recently approved 2 new and approved vaccines for pneumonia, we are particularly focused on what is being done to ensure we are doing everything possible to protect American seniors. Will seniors have access to the best available vaccines to ensure they are as protected as possible? These new vaccines offer hope and even greater protection against life-threatening disease for some of the most vulnerable in our population, but only if they have access to them. We urge ACIP to consider expediting the vote on these vaccines ahead of the upcoming October meeting to ensure the broadest availability possible for America's seniors ahead of this year's flu pneumonia season. Thank you very much.
Thank you for your comment. Our next speaker is Ms. Claire Hannon. Ms. Hannon, please.
Thank you. I'm Claire Hannon, Executive Director of the Association of Immunization Managers. I wanted to take this opportunity to thank the committee for its steadfast commitment to evidence, data, and science. I would also like to recognize and thank the public health workers across the nation and throughout the U.S. territories and Pacific Island nations for their dedication in containing the pandemic and vaccinating the adult population. Today's meeting of the ACIP is just one of 15 special meetings that have been conducted in addition to regularly scheduled meetings conducted in public since the pandemic began. During these committee meetings, members review findings and discuss vaccine research and scientific data. The recommendations of the committee's medical and public health experts guided the use of COVID vaccine and ensured a vigilant, watchful eye on all potential side effects. To the committee and the expert staff and leadership of the CDC, thank you. At the start of this pandemic, our public health workforce was significantly less than previous years. According to data from the Association of State and Territorial Health Officials, the number of public health workers went from 236,000 at the start of the H1N1 pandemic in 2009 to 206,000 workers at the start of the pandemic in COVID-19. Turnover in public health is high. Of the 64 federally funded state, territorial, and large city immunization programs, AIM members, 32 have experienced turnover with their program manager since 2019. The burnout and exhaustion in public health is real. To all the public health workers and especially the immunization program managers, thank you. They're working long days, nights, and weekends to plan and implement the vaccination campaign has resulted in much success and impact. 68% of adults with at least one shot, 160 million people fully vaccinated, 336 million doses administered. Epidemiologists at Yale University estimate that New York City's vaccination campaign has prevented 250,000 COVID-19 cases, 44,000 hospitalizations, and 8,300 deaths. Between January 1st, 2021 and June 15th, 2021, 98% of hospitalizations and 98.8% of deaths from COVID-19 were in those who were not fully vaccinated. So clearly our work is not done. But again, I just want to say thank you to the committee and all those involved in these efforts. The nation is extremely grateful. Thank you.
Thank you very much, and thank you to all those vaccinators across America that are delivering these vaccines. Our next public comment will come from Mr. Philip Canuto. Mr. Canuto.
My name is Phil Canuto, and I live in Akron, Ohio. My cousin gave me a kidney 19 years ago. I'm in the Johns Hopkins vaccine transplant study, and I tested negative for COVID antibodies after both my Pfizer jabs. I appreciate the opportunity to represent immunosuppressed patients today. I urge you, beg you even, to recommend that we be able to receive a third vaccine dose and to allow doctors to make an additional dosing decision on a case-by-case basis. When a friend got her first Pfizer shot, she cried with happiness for the freedom the shot offered her. But those of us who are immunosuppressed have no such freedom. Instead, we exist in an uncertain limbo. We're told to behave as if we are not vaccinated. Continue to mask up, our doctors say. Social distance. Avoid crowds and poorly ventilated spaces. And now the Delta variant increases our risk. So what are we to do? Many of us must take risks that could lead to exposure, illness, and death. Hundreds of us lie to pharmacies and immunization sites about our previous vaccinations, trying to get an extra unauthorized dose. I know that's what I'll be doing if additional doses are not sanctioned. And we long for a fuller life. For me, it's for family, music, and food. I can't wait to see my stepdaughter's new Colorado home, to hear Lyle Lovett live in concert, to eat a medium rare steak at the Diamond Grill. But I'm retired. I can control my activities. What about transplant patients who must check out groceries or manage an office? They have no safety net. They risk exposure every day. So please recommend additional shots for us. I know even then there will be uncertainty. I know there is no guarantee that a third or even a fourth dose will provide us with full immunity. But I want that chance. And even if that extra dose doesn't keep me from getting sick, maybe it can help me avoid a ventilator or death. Neither Johns Hopkins nor the French have found meaningful adverse events in patients who have taken a third dose. So the risk of these extra shots, while not nothing, seems very, very small. But the benefit could open up the world to us again. Thank you for this opportunity to speak.
Thank you for your comment. Our next speaker will be Mrs. Erica DeWald. Mrs. DeWald.
Thank you. Thank you for the opportunity to comment. My name is Erica DeWald. I am Director of Strategic Communications and Partnerships for Vaccinate Your Family, a national nonprofit organization committed to protecting people of all ages from vaccine-preventable diseases. I'm also a mother and a daughter who has celebrated each and every age expansion for the COVID-19 vaccine. I'm hopeful I'll be able to protect my two young children against this really devastating disease, as we've heard in these comments thus far, in the near future. Our organization deeply appreciates the work of this committee. Your careful deliberations this morning show firsthand how carefully you consider even the rarest safety signal for all vaccines, not just COVID-19. Transparency is key in these conversations. As you all know, risk-benefit is a difficult calculation for many of us to make, especially when it's regarding our own health and that of our loved ones. The information you share, particularly in plain terminology, helps all of us better communicate the risk-benefit of vaccines versus the diseases they prevent when speaking to the public. And I would like to take this opportunity to remind you that the public overwhelmingly supports vaccines. The proof is in the 160 million people in the U.S. now fully vaccinated against COVID-19. In fact, trust in vaccines increased after the FDA, ACIP, and CDC worked together to investigate concerns about low platelet counts in combination with blood clots following vaccination with the Jansen COVID vaccine. That interagency coordinated communication is key to continuing to increase confidence. But people do want more information and answers to their questions. It's critical that we direct people with questions to science-based information. My hope is that they will seek out reputable sources such as CDC, a trusted healthcare professional, or advocacy organizations like my own, Vaccinate Your Family. Thank you again for your time today and for all you do.
Thank you very much for your comment. That completes our public comment session for today. I want to thank the public commenters for their words. Oop, excuse me. It seems like there is one more. I forgot one then. Who is? Mr. John. Oh, he's on the list here? Okay. Sorry, we're not on our list. Mr. John Gilmore, please go ahead.
Yes, thank you. My name is, can you hear me?
Yes, we can.
Thank you. My name is John Gilmore. I am the Executive Director of Children's Health Defense New York. We're an advocacy organization working on a wide range of issues affecting the health and well-being of children, including vaccine rights and vaccine policy. I also lost my mother to COVID last year when she contracted it in her nursing home here in New York. So this is an issue I take very seriously. My comment today is that the identification of Guillain-Barré syndrome as an injury associated with the Johnson & Johnson COVID shot, following so closely on the discovery of the association with myocarditis after millions of doses have been administered, underscores how little we really know about the potential side effects, not only of the Johnson & Johnson product, but also the COVID products currently used in the United States. This lack of knowledge is exactly why these products are only available under an emergency use authorization. This lack of knowledge about both immediate and long-term impacts of these products screams for caution and prudence in the use of these products. In light of our lack of information, in combination with the Countermeasures Injury Compensation Program, placing the overwhelming burden of risk upon the person receiving the shot, we believe it is incumbent upon the ACIP to reject any measures to coerce compliance with compulsory vaccination measures by both public and private actors. The person receiving the shot should make this decision based on their own evaluation of the risks and benefits of doing so. And these decisions should be made for minor children only by their parents and no one else. Now, some states, on a related issue, are citing the lack of knowledge about these products and the lack of guidance from ACIP as a reason to disallow any medical exemptions written by the patient's own treating physicians. I have already encountered personally several instances of these refusals in New York, and I'm sure they are occurring elsewhere. Okay. Consequently, I believe the ACIP, should issue a policy when it comes to medical exemptions, deferring to the opinion of the treating physician in all instances, especially given our lack of information that we have right now. So thank you for the opportunity to speak today, and good day.
Thank you very much. And that ends our public comment session. We're going to move on to now presentations by Dr. Rosenblum and Dr. Mbe. And then we will take questions and discussion after the presentation of both. So let's begin with the first presentation by Dr. Rosenblum on COVID-19 vaccines benefit risk discussion. Dr. Rosenblum.
Good afternoon. Next slide. Today's discussion will focus on the benefits and harms of COVID-19 vaccines in adults. This includes the 3 COVID-19 vaccines recommended for persons age 18 and older in the United States under FDA's emergency use authorization. Next slide. First, to frame this presentation, the goal of this analysis was to assess the benefit-risk balance of the Jansen vaccine given recent reports of Guillain-Barré syndrome in vaccine recipients. The previously presented analyses for TTS and Jansen vaccine and myocarditis and mRNA vaccines have been updated so that the benefit risks of COVID-19 vaccines can be comprehensively assessed and discussed. Next slide. I'll begin by showing updated information on the public health problem, briefly reviewing recent COVID-19 epidemiology in adults and the 3 potential harms. Next, I'll review benefits of Janssen vaccine and the potential harms by estimating risk of GBS and TTS. Following that, we'll do the same for benefits of mRNA vaccines, along with the updated estimates of potential risk of myocarditis in adults. Next slide. This figure shows the number of COVID-19 cases in the United States reported to CDC over the pandemic. Since January 2020, there have been more than 33 million cases. Overall, these have been declining since January 2021. Next slide. We can take a closer look at cases from April through July. Next slide. While this past spring, the number of COVID-19 cases was decreasing, the end of June appears to have been a nadir in the United States. Over the last few weeks, the number of cases has begun to rise. For the benefit risk assessment will show, we have used case incidence and hospitalization rates from the week ending June 19th. Because that may represent the trough for COVID-19 cases, these estimates should be interpreted in the context of this trend. Next slide. These 2 figures show this week's national Ensemble Forecast from CDC. The left panel represents the trend of predicted newly reported COVID-19 cases over the next 4 weeks, and the right panel shows predicted COVID-19 new hospital admissions for the next 4 weeks. This week's forecasts predict that over the next 4 weeks, the number of daily COVID-19 hospital admissions will likely increase. Next slide. These are the latest national nowcast projections of the proportions of SARS-CoV-2 variants from CDC's data tracker. Lineages that are variants of concern are shown in orange. For the most recent week through July 17th, which appears farthest to the right, Delta variant is in the darkest orange and makes up the largest proportion at more than 80%. Next slide. Next, we'll move to the potential harms following COVID-19 vaccines. A greater than expected number of cases of Guillain-Barré syndrome, a rare neurological disorder, have been reported following Janssen vaccine. These have been within 2 weeks of vaccination, mostly in males and in those age 50 and older. Thrombosis with Thrombocytopenia Syndrome, or TTS, a rare but clinically serious adverse event, has also been observed following Janssen vaccine. Most cases have been in females age 18 to 49. ACIP is familiar with the TTS benefit-risk balance assessment and discussions from April after the pause and the ultimate resumption of vaccine administration when benefits were felt to outweigh risks. Myocarditis is also rare, but has been observed following mRNA vaccination. This has been most commonly observed in young males under age 30 and more frequently after the second dose. The benefit-risk balance was presented for adolescents and young adults recently to ACIP. The focus of today's discussion will be in adults 18 and older. Next slide. In summary, while overall COVID-19 incidence has been decreasing, the U.S. may have reached a low point in June, and we have begun to see cases and hospitalizations rising in recent weeks. Variants of concern continue to spread, and Delta variant is now found in more than 80% of U.S. cases. The rare adverse events listed here have been observed after COVID-19 vaccination. Next slide. Now we'll move to the benefits and harms of Jansen COVID-19 vaccine. Next slide. We used a similar direct estimation approach as was used in April for TTS and recently for myocarditis to estimate direct benefits and risks of Jansen vaccination. The benefits included estimation of COVID-19 cases, hospitalizations, ICU admissions, and deaths prevented per 1 million doses of Jansen vaccine. These calculations were based on the most recent age and sex-specific incidence of hospitalizations from COVIDnet ending the week of June 19th, vaccine efficacy against hospitalization and symptomatic COVID-19 from the phase 3 trial, and assume a 120-day period of not being vaccinated. Next slide. The potential harms of the Janssen vaccine were also estimated per million doses by age and sex using GBS cases from the Vaccine Adverse Event Reporting System, or VAERS, through June 30th. The same was estimated for TTS using VAERS data through July 8th. Next slide. For benefits, in the phase 3 clinical trial, the Janssen vaccine was found to have an overall efficacy of 66% against symptomatic lab-confirmed COVID-19. Vaccine efficacy against hospitalization was 93%. Both persistence of antibody response following vaccination and activity against a variety of variants, including the Delta variant, has recently been shown. Next slide. This slide shows the cases of Guillain-Barré syndrome reported to VAERS following Janssen vaccine by sex and age group. As of June 30th, there have been over 12 million doses administered and 98 cases with age and sex information reported to VAERS. Cases were greatest among 50 to 64-year-old males with a reporting rate of 15.6 per million doses. Next slide. This slide shows the cases of thrombosis with thrombocytopenia syndrome observed following Janssen vaccine by sex and age group. As of July 8th, there have been 38 cases of confirmed TTS. Cases are greatest among 30 to 49-year-old females with a reporting rate of 8.8 per million doses. Next slide. These next series of slides show the predicted cases of COVID-19 hospitalizations, ICU admissions, and deaths that are prevented compared to the estimated number of GBS and TTS cases for every million Janssen doses over 120 days by age group and sex. What follows is a slide for each age group with females on the left and males on the right. The benefits are shown in black above the line and the risks are shown in red below the line. Beginning with females age 18 to 29, we estimated that for every million doses, 8,900 cases of COVID-19, 700 hospitalizations, 50 ICU admissions, and 5 deaths would be prevented, and we estimate that we might see 1 GBS case. For males age 18 to 29, we estimate that per 1 million Janssen doses, 6,600 cases of COVID-19, 300 hospitalizations, 60 ICU admissions, and 3 deaths would be prevented, and we might see 2 GBS cases. Next slide. With the same benefits described among 18 to 29-year-old females, we also estimate 4 to 5 TTS cases, and among 18 to 29-year-old males, we estimate 2 to 3 TTS cases. Next slide. For the next age group, thousands of cases of COVID-19 and hundreds of hospitalizations are estimated to be prevented, against 6 to 7 cases of GBS for females, 8 to 10 cases of TTS for females, and 7 to 8 cases of GBS in males. Next slide. For individuals aged 50 to 64 years, the benefit-risk balance is even more favorable, with still more COVID-19 outcomes prevented compared to GBS and TTS cases. In this age group, we estimated seeing 14 to 17 GBS cases among males. Next slide. And in the oldest age group, 65 and older, the benefits are even greater. Next slide. This figure shows prevented COVID-19 hospitalizations in lighter blue and prevented COVID-19 deaths in darker blue per million doses of Jansen vaccine on the left, compared with cases of GBS and TTS per million Jansen doses expected on the right. These are shown by age group, with data among females appearing above the line and data for males appearing below the line. You can see the favorable balance of vaccination compared to the potential harms. Next slide. Next, I'll describe the benefits and harms of mRNA vaccines in a similar format. Next slide. We used the same direct estimation approach described earlier to estimate the benefits and risks per million doses of mRNA vaccine. Benefits were again estimated to include COVID-19 cases, hospitalizations, ICU admissions, and deaths prevented. Calculations were based on the most recent age and sex-specific incidence of hospitalizations from COVID-19 ending the week of June 19th, as well as mRNA vaccine efficacy observed in phase 3 trials, and also using a 120-day period. Potential harms of the mRNA vaccines have been estimated per million doses by age and sex using VAERS data through June 30th. Next slide. The benefits of mRNA vaccines are listed here on the slide. The phase 3 clinical trials for Pfizer and Moderna mRNA vaccines showed overall efficacy of 94 to 95%, with vaccine efficacy against COVID-19 hospitalization of 89 to 100%. The persistence of antibody response for months following vaccination and activity against a variety of variants is also noted for mRNA vaccines. Next slide. This slide shows the cases of myocarditis observed following second doses of mRNA vaccination by sex and age group. As of June 30th, there have been about 141 million second mRNA vaccine doses and 497 cases of myocarditis reported following the second dose. The greatest number of cases has been observed in 18 to 29-year-old males, with a reporting rate of 24.3 per million doses. Next slide. These next several slides are similarly formatted to what has been shown earlier in the presentation and display the benefits of mRNA vaccines in black above the line against the estimated cases of myocarditis in red below the line for every million doses of mRNA vaccine by sex and age group. For 18 to 29-year-olds, we estimate many thousands of cases of COVID-19, hundreds of hospitalizations, 50 to 60 ICU admissions, and 3 to 5 deaths prevented per million mRNA doses. For females, 3 to 4 myocarditis cases might be seen, and for males in this age group, we expect 22 to 27 cases of myocarditis. Next slide. As we review older age groups, the benefit-risk balance is more favorable, with more outcomes prevented and fewer myocarditis cases estimated. This slide shows 30 to 49-year-olds. Next slide. This slide shows estimates for 50 to 64-year-olds. Next slide. And this slide shows estimates for age 65 and older. Next slide. This figure shows prevented COVID-19 hospitalizations in light blue and prevented COVID-19 deaths in dark blue per million doses of mRNA vaccine on the left, compared with cases of myocarditis per million doses estimated on the right. For each age group, females are shown above the line and males are below the line. You can see the favorable balance of vaccination compared to the potential risk. Next slide. Next, I'll summarize the benefit-risk balance for COVID-19 vaccination. Next slide. These final two visualizations show the COVID-19 hospitalizations and COVID-19 deaths prevented by vaccines on the left compared to risks on the right. Here, the Jansen vaccine data appears above the line, and the mRNA vaccine data appears below the line. This slide with data for females again shows that the estimated benefits outweigh risks of vaccination for GBS, TTS, and myocarditis. The difference in hospitalizations and deaths by vaccine is owing to a small difference in vaccine efficacy. Next slide. Here's a similar visual with data for males, again with Jansen benefits and risks shown above the line, and mRNA vaccine benefits and risks shown below the line. The benefit-risk balance among males also favors vaccination. Next slide. Finally, the prevented COVID-19 outcomes against the potential harms are summed here in one table by age group, sex, vaccine, and event. As you can see, many hospitalizations, ICU admissions, and deaths can be prevented through Jansen and mRNA COVID-19 vaccines, far outweighing the rare risks of adverse events. Next slide. This summary slide shows the overall reporting rates for these rare adverse events. For TTS, 3 cases per million Janssen doses have been observed among all adults. For GBS, 7.8 cases per million doses of Janssen vaccine have been reported. For myocarditis, 3.5 cases per million doses of mRNA vaccine have been reported. Next slide. Our model likely underestimates benefits for a few reasons. First, cases in general may be underreported, and COVID-NET might not capture all COVID-19 associated hospitalizations. The model uses case incidents and hospitalizations from a snapshot in time and does not account for rising case counts. Second, these benefits are estimated over 120 days following vaccination, but protection from vaccination likely lasts longer. Third, the prevention of post-COVID-19 conditions is not accounted for. A few additional limitations to mention: some of the hospitalizations used might be related to diagnoses other than COVID-19. The vaccine efficacy used was from clinical trials because there's limited data about real-world efficacy for input. And last, certain estimates for harms were from crude numbers of adverse events to VAERS, which is a passive surveillance system. Not all events that are reported following vaccination have been confirmed to meet case definitions. Next slide. In summary, this direct approach benefit-risk assessment for Janssen vaccine and similar direct benefit-risk assessment for mRNA vaccines each consider individual benefits of vaccination versus individual risks, which can help us inform policy. Each shows a balance of benefits that far outweighs potential risks. As described, this relative balance of benefits and risks for individuals does vary by age and by sex. Next slide. There are many people to thank for their contributions to this analysis and putting together this presentation. Thanks very much.
Thank you very much for that excellent presentation. So next we're going to move on to work group interpretation and next steps by Dr. Sarah Mabey. Dr. Mabey?
Good afternoon. Today I will present the work group's interpretation of the benefits and risks of COVID-19 vaccines. Next slide. After a period of decline, COVID-19 cases are rising again, fueled by the spread of the highly transmissible Delta variant, which now accounts for 83% of U.S. cases. Next slide. Over 2/3 of U.S. adults have received at least one COVID-19 vaccine dose, and approximately 60% are fully vaccinated. However, coverage varies in the population by age, geographic location, race and ethnicity, among other factors. Next slide. At the local level, low vaccination coverage places individuals and communities at risk. In this figure, counties with the lowest vaccination coverage and highest disease incidence rates are shown in bright red, and counties with the highest vaccination coverage and lowest incidence rates are shown in bright green. We can see that hotspots have emerged in areas where vaccination coverage is lagging. Next slide. mRNA vaccines account for the majority of the over 338 million COVID-19 vaccine doses administered in the United States to date. Janssen accounts for 4% of doses administered, which has remained consistent before and after the April pause. Next slide. However, willingness to receive Janssen vaccine remains lower since the April pause. Among people who haven't yet received a COVID-19 vaccine but who plan to get one, 26% of people say they would be willing to get a Janssen vaccine. Next slide. To inform ACIP discussions, we conducted a survey of jurisdictions to better understand the current use of Janssen vaccine and how it relates to patient choice, access, and vaccine equity at the state and local level. 83% of jurisdictions report that most vaccination sites offer more than one type of vaccine at that site, which helps to ensure that patients have a choice in vaccine product. In addition, Janssen vaccine is used in a variety of populations and settings, including in rural populations, mobile clinics, corrections populations, persons experiencing homelessness, primary care provider offices, and college students, among other groups. Thus, Janssen vaccine likely remains important for reaching disproportionately affected populations and for achieving vaccine equity. Next slide. We know that the benefits of the currently authorized COVID-19 vaccines are unequivocal. All of the vaccines are effective against COVID-19, including serious outcomes like severe disease, hospitalization, and death. Available evidence also suggests that currently authorized vaccines offer protection against known circulating variants, including the Delta variant. And a growing body of evidence indicates that people fully vaccinated with an mRNA vaccine are less likely to have asymptomatic infection or to transmit SARS-CoV-2 to others. Next slide. However, rare serious adverse events have been reported after vaccination. Thrombosis with Thrombocytopenia Syndrome and Guillain-Barré syndrome after Janssen vaccination, and myocarditis after mRNA vaccination. Next slide. While rare but potentially serious risks of COVID-19 vaccines have been reported, the updated benefits-risk evaluation that Dr. Rosenblum presented continues to show that the benefits of vaccination outweigh these risks across vaccine types, age, and sex, as summarized in this table. The model demonstrates that for every million doses of vaccine administered, thousands of hospitalizations, ICU admissions, and deaths can be prevented. Next slide. Taken together, the workgroup's interpretation is that vaccination continues to be critical during this period of rapidly increasing cases and spread of variants of concern. The reported adverse events, TTS, GBS, and myocarditis, are potentially serious and should be transparently communicated with the public. Even with the new GBS safety signal, the benefits of Janssen vaccination continue to outweigh the risks. Next slide. In addition to the benefit-risk profile, the workgroup discussed the importance of patient choice in vaccine product, access to vaccines for disproportionately affected populations, confidence in patients and providers to understand the benefits and risks of vaccines and to make informed decisions, the need for communication and educational materials around these rare risks, and the implications of any change in vaccine recommendations on global vaccine confidence and use. Next slide. The workgroup reaffirms that all eligible persons should receive a COVID-19 vaccine. Patients and providers should be aware of both the benefits and risks of COVID-19 vaccination when choosing a vaccine product. And the workgroup expressed strong support for the continued use of Janssen vaccine according to the current recommendations. Next slide. The workgroup also emphasized the importance of clinical education and communication materials to help support patient-provider decision-making. CDC will be updating its clinical considerations to state that persons with a prior history of GBS can receive any of the authorized vaccines. However, given the possible association between Janssen vaccine and GBS, patients with a history of GBS and their clinical team should discuss the availability of mRNA vaccines to offer protection against COVID-19. The clinical considerations will also provide information on GBS signs and symptoms and when to seek care. Next slide. CDC will also be updating other clinical resources and tools, such as the standing orders and pre-vaccination checklists. Next slide. In addition, CDC will be updating some of its communication materials, including information for providers on talking to patients about Janssen vaccine safety and updated frequently asked questions. Next slide. For discussion today, we'd like to ask ACIP for their interpretation of the benefits and risks of COVID-19 vaccination. And does ACIP agree with the workgroup's interpretation that Janssen COVID-19 vaccine should continue to be used according to the current recommendations? Thank you.
Thank you both for those excellent presentations. Let me just pull up my list here of participants. So I'm going to ask the voting members to respond to these questions They can also ask questions or make comments related to the two presentations that were just given. And let me begin by asking one, and I don't want to get off the main topic, which is GBS today, but when will the ACIP have data on myocarditis in the 12 to 18-year-old group for review, please, if you have any information on that? And I'm sorry to derail the conversation, but I'm sure everyone is waiting for something like that.
No, totally fine. This is Dr. Oliver. So we're actively working on that right now and plan that when we present data to discuss the Mrna adolescent vaccine, we'll be able to present an updated assessment of the benefits and risk of myocarditis in adolescents at that time.
Thank you very much for that. So let me call on Ms. Bata, who has her hand up at this time.
Thank you. And I appreciate the clarity of these presentations. In looking at your presentation, Dr. Rosenblum, you talked about using the efficacy data from the clinical trials. Are we planning to pull in some of the real world data and use that? I think that could affect our understanding of the benefits and the risks, or maybe it's been done and it's irrelevant. I don't know. And in terms of the interpretation, based on what was presented, I'm very supportive of where we're headed in using the Jansen vaccine for the prevention of COVID-19. Thank you.
Thank you very much.
Dr. Bata, this is Dr. Oliver. Absolutely. As we continue to get more information on real-world efficacy, duration of protection, all of that, those will be incorporated into future benefit-risk analyses.
Thank you for that comment. Okay, then, I'm sorry. No, I thought maybe there was another comment here on the room. Okay, are there any other comments or questions or answers from the voting members? Dr. Sanchez.
Thank you, Jose. Sorry, I was slow in unmuting. I definitely agree that the overall benefits of COVID-19 vaccines far outweigh the risks. I mean, it's been a tremendous boon. The COVID vaccines highly efficacious, and certainly I'm very pro in their administration. However, I am concerned about the Janssen product. I am concerned that that the risks associated with the Guillain-Barré and the TTS they're not benign, and although rare, they're quite significant, and certainly a lot more than the cases that at least have been presented to us previously on the myocarditis in younger individuals that tend to be milder. So I personally prefer the messenger RNA vaccines, and I think, though, that I have no problem continuing to have the Janssen product available, but I think that those risks have got to be stated upfront to the person who's receiving that vaccine. And they may have choices of vaccines available in many jurisdictions, but at least locally, what I find is that there's only one product. But I think that it just concerns me. And personally, if it were my choice, at this time, from what I know, I would recommend the messenger RNA vaccines over the Janssen product. Thank you.
Thank you for those comments. Dr. Long.
Hi, I'm right on Dr. Sanchez's wavelength. And I thank you for all of this careful information and your thoughtful comments, and it seems that we're collecting here today the benefits and the risks of all of the vaccines that we know about so far. And in the spirit of that, I think it is interesting, and I think it is right to say about the Guillain-Barré syndrome in those who have a history of Guillain-Barré syndrome, that there should be a discussion of other vaccines, of mRNA vaccines that are available to the person. I just am sorry and want us to say the same things for myocarditis, for cerebral venous thrombosis, about the other vaccines. So I don't know why we're taking that one approach for the history of Guillain-Barré, but we're not taking the approach for the potential for this unusual occurrence of these three things with these specific vaccines. And the other thing that I know I read in the things that I received, that it was somewhere said that the patient should be aware. And I objected to that omission of the word made aware. So the patient should be aware, puts the burden on the patient, where I think the burden should be on the vaccinator, that the patient be made aware of the complications and the patient be made aware of other vaccines that potentially could be used. And the last thing I'll say about these things, for now at least, is that there's a little bit of a mismatch of the data presented by Dr. Rosenblum and Dr. Oliver about in the omission of those under 18. And I think it is becoming clearer and clearer, at least with the manuscripts I'm receiving at the Journal of Pediatrics and other reports, that this is a more common complication, myocarditis, in those under 18. And yet, I understand why we might not be saying much about them as you're looking at the data day to day. We're making the recommendation that all individuals should be vaccinated when they are eligible. So that does include the 12 to 18-year-olds. And I don't know that there's anything different that we might want to say here after already having a warning about myocarditis. But I think that we're in a little bit of a difficult place until we very rapidly see the data and see what we want to say about the relative benefits and risks in that slightly younger age group than the majority or the 18-year-olds. Thanks. Sorry that it was long-winded, Dr. Romero.
No, thank you for those comments. And again, we will be talking about myocarditis in the 12 to 18-year-old group in the near future. So we're not skipping them at this point. It's just that we don't have that data formulated for presentation.
Sorry, this is Dr. Oliver. And then the focus today was kind of putting everything in context around the Jansen and the GBS signal. And as the 18 and over population is the population that we have all three of those vaccines authorized for, that's the focus of today. As we move into a younger population where we may have the other vaccines, that'll be the focus for that day. But today is the three vaccines available for 18 and over and the benefit and risk balance of those three vaccines.
So I'm going to ask that the fourth slide of this presentation be brought up before I call on on Ms. McNally. So if you look at that slide, you'll see the bright red area, which is Missouri and Arkansas. And we are in the midst of a Delta upsurge. There's no question about it. Our cases have more than doubled in 2 weeks, and our death rate is increasing. I think it's important that we have available to us all 3 vaccines at this time for the public to use as they see appropriate, and that they be allowed to choose this because there are clearly individuals in my state that will not come back for a second dose. And having that access to a single dose vaccine is a very important part of our strategy to move out of this situation. Now, we know that we cannot vaccinate ourselves out of this problem without physical mitigation measures, but vaccination is extremely important. So my comment is that I am in favor of the presentations today and the decisions. We can move to the questions, please. Mike, Chris, can you put the questions back up for the last slide? And I believe that at this time, we continue with the work group's interpretation that Jansen COVID-19 vaccine should continue to be used according to current recommendations. And I agree that we should have, when possible, and in most cases that it is possible, to have alternative vaccines available for the public to choose from. So I'll end my statement there. And Ms. McNally, please go forward.
Thank you. On the question about whether we agree with the work group's interpretation that the Janssen COVID-19 vaccine continue to be used according to the current recommendations, I really just want to state that as the consumer representative, I found slide 10 of Dr. Mbai's presentation to be extremely helpful in evaluating the benefits of vaccination and the risks. So thank you for that information and in that slide format. With respect to health literacy concerns regarding GBS and other effects from vaccine that could result, I just wondered if CDC could comment on the discussions that go into the talking points for patients and the information that goes on the website in terms of explaining what GBS is. Thank you.
Sure. Thank you for that question. Yes. And, we, for kind of explaining this to the public as well as, healthcare providers, we have communication specialists that work with the scientific information to drill it down in a format that is accessible to the public, accessible to various levels of literacy and understanding about the vaccine. So that is absolutely a consideration in terms of making those materials. As well as, for, some of our materials on the web, you've noticed that they've been translated into different languages. So there are a lot of efforts to make those as kind of accessible to the public.
And just to follow up, are you receiving positive feedback regarding the information that's being provided for vaccinators?
We are, yes. And I think specifically, around some of these adverse events, when TTS was first reported and CDC put out updated communications materials about that, we did receive a lot of positive feedback that they were helpful for providers in explaining, the information to patients, as well as the kind of general consumer content as well being helpful for the public. So we have received positive feedback, and we do monitor kind of the metrics on our website, how many people, click on them, how many people review them, and we see that we get a lot of traffic, a lot of people are accessing our materials.
Ms. McNally, does that answer your question?
Yes, it does. Thank you very much.
Thank you. Dr. Daly, please.
Yeah, thank you so much. I'd like to make a couple comments at this point. First, I really want to thank Dr. Sanchez and Dr. Long, because I really appreciate their comments. I mean, I think they're capturing what we're all feeling, in the sense that we really want to maximize our ability to prevent as much disease as we can. while at the same time maximizing the safety of these vaccines in any way that we can. So in that context, I just want to assure the entire ACIP that the COVID vaccines work group is going to continue to scrutinize every piece of data that we have very closely. I mean, we're meeting weekly, and we can meet more frequently than weekly if needed, because the situation is really going to evolve. And so we're going to get new data about the effectiveness of these vaccines against variants. We will over time get more precise estimates of really what the risk is of these rare but serious adverse events. We'll also get more data over time about any long-term consequences of the myocarditis cases, for example. And these are just examples of some additional data that we'll get. But then I think a point I'll also make is echoing on some comments that Dr. Romero said. You know, I have patients in my practice that, for example, a very athletic young adult male, and that individual is more concerned about myocarditis than he is about GBS or TTS. And I think we'd all argue that getting any vaccine is better than getting no vaccine. And so that's why I would support all three products being available. And if multiple products are available in a single place, then it makes that conversation earlier. And as long as we're communicating as best we can the risks and the benefits, and then allowing providers and patients to make decisions for themselves. So that concludes my comments. Thank you.
Thank you, Dr. Daly. Dr. Paling.
All right. I want to say thank you to Dr. Rosenblum and for a great and very clear presentation. I also very much appreciate the fact that they're putting in the potential benefits based on the current vaccine or the current rates of COVID hospitalization and disease that we're seeing. I believe I found Dr. Lee's slide showing the COVID-19 disease rates per million, or deaths per million by vaccine coverage by state. Very compelling, demonstrating that states with low vaccine coverage have the highest COVID-19 deaths per million, and the states with the highest coverage have the very lowest. The Delta variant is clearly circulating and is more contagious and seems to be causing more disease. So I do agree with the ACIP work group's interpretation of the benefits and the risk. I would like to look at slide 10 because I too found this very important. And my earlier question about myocarditis and verifying the cases associated with Mrna have been mild and recover quickly is important for the 18 and 29-year-old as I'm looking at that. And so that's an important factor for me to consider. When I look at the risk and benefits, I'm going to agree that the benefits outweigh the risk, and then also agree the importance of clearly communicating both the benefits and the risk to everybody. And in that, we've had a discussion about health literacy and making sure all the materials available are in appropriate health literacy so that we can really clearly communicate this information. That's it. Thank you.
Thank you for your comments. Sorry, I'm having trouble with my list. Dr. Bernstein, go ahead.
Yes, thank you. Wonderful presentations as always, and I totally agree that we need as many COVID vaccine products available as possible, and if there's with close to 15 million people not coming back for their second dose of mRNA vaccines, having a single dose product available is important. My question relates to, at the beginning, the FDA talked about that there were next steps included obtaining additional follow-up and medical records for the Jansen reports and evaluating those reports to determine whether they meet Brighton collaboration case definition of GBS, and then based on the number of confirmed cases, reassess the observed to expected analysis for GBS after Jansen. I wondered whether the work group interpretation would be different, perhaps, after all of these cases are adjudicated, or how it might influence their thinking or interpretation.
Thank you. Dr. Shimabukuro, could you potentially comment on, the adjudication of cases and where things are at with those?
I would have to talk to the FDA folks that are reviewing them. I mean, historically, the confirmation rate of GBS cases to VAERS has been pretty good. Just want to remind that VAERS is a passive surveillance or spontaneous reporting system, and we do have other population-based systems where we're looking at GBS, particularly the vaccine safety data link, although there are limited data there. So I think that looking at the chart confirmed the chart confirmed rates in VSD, along with the adjudicated cases in VAERS, when we can complete those reviews, certainly will be informative. But just again, historically, for VAERS cases, those confirmation rates have been pretty good, pretty high, relatively high.
Yeah, and this is Grace Lee. I'll just comment, since you had asked about the interpretation. I think what we would plan to do is we anticipate that these are dynamic numbers, and everyone is trying to look at all the data in real time. So we do anticipate some changes, but again, we'll look at the totality of the evidence across all the federal safety systems. Given what information we had, we did feel it was important to bring forward and discuss on today's call. So the numbers might change slightly. I don't know if we anticipate any significant changes, but we will continue to update and review that data, and any new information will be shared with the ACIP COVID vaccines work group and the ACIP as time moves on.
Thank you. I just had another question related to that, and I may have missed this, but with the myocarditis that there was specific to the younger age group, the teenagers and the young adults, and with the TTS, it was females 29 to 49 or something along those lines. Are the information that's being added to the EUA fact sheets tailoring it to a specific age and or gender around GBS risk?
Dr. Fink, do you have any comment on that from the FDA?
I'm sorry. Can you give me a minute to just confirm? I need to pull the fact sheet up.
Thank you very much. We'll just let us know when you're ready. Dr. Bernstein, anything else?
No, thank you.
Thank you. Dr. Fry, please.
Thank you, Dr. Romero. I'll just be very brief. I do agree with what you said about having all three vaccines available. There are a lot of people who really just want the single dose vaccine. And I think the events remain rare. So the risk benefit leans towards benefit of receiving these vaccines in so many ways. I live in Missouri, and I understand that people do not want to be vaccinated for multiple reasons. One, it's not a fully FDA approved vaccine, but the other reason is one of several, is that people feel that, it should be their right to choose whether or not they want to be vaccinated. But there are many people who would like to have that single vaccine available, and I think that's perfectly fine. Again, the events are rare. And so I'm throwing my weight for that we continue to provide these vaccines, but I also want to state that if I was going to be the recipient of these vaccines, knowing what data there is out there, that I would like to have that data provided to me as a receiver of vaccine. And I think that's what we need to be able to accomplish, is making that data available to people so they can choose what's best for them. Thank you.
Thank you for those comments. Dr. Fink, I see your hand is up, so I think you're prepared. Thank you for answering these questions.
Sure, and thanks for the additional time. So I just wanted to make sure that I was providing completely accurate information. But the EUA fact sheets for the Jansen COVID vaccine, which have been available on the FDA website since last week, state that reports of adverse events following use of the Janssen COVID-19 vaccine under emergency use authorization suggest an increased risk of Guillain-Barré syndrome during the 42 days following vaccination. So we don't say anything more detailed than that. That is the statement that we thought the currently available data would support.
Thank you. Dr. Sanchez?
Thanks, Jose. I had actually a question. I mean, a lot of it's been said about the advantages of a single dose vaccine, which I absolutely agree. You get one done, you get it, and that's it. But do we know the reasons why they're not coming in for a second dose? I don't know. I'm not aware, and that may have been looked at. Is it the inconvenience, or is it because they've had side effects after the first one? Or are we dealing with a hard-to-reach population?
Dr. Oliver will offer comment. Thank you.
Hi, Dr. Sanchez. So Jansen has said that they have a 2-dose study ongoing, and that we expect results for that in the future. So we, anticipate getting results on 2 doses of a J&J vaccine in the near future, and we'll bring those to ACIP as they're available.
But that's not my question. Thank you, Sarah. My question is, do we know why people have only gotten 1 dose and have not come back? Has there been any analysis of why they're not coming back for a second dose?
I don't know if anybody here wants to offer comment. I can make comment based on what we have learned in our state. And this is not scientific. This is just a random polling of people, but it seems to be that it's the adverse effects that we know occur, and that they're not willing to lose time from work or from their activities to deal with those effects. And they're not, at least from what I can tell, not out of the ordinary than what's been reported. But I don't know of any other really evidence-based comment on that. So I'm sorry. Dr. Cohn, do you have anything to say?
Yeah, I'll just add that the return rate is actually extraordinarily high compared to other adult vaccines, such as hepatitis vaccines. And I think this is similar, if not higher, than the zoster second dose return rate. So, we actually, this is sort of on par with, this is actually better than expected. But I agree with, in general, Dr. Romero's sense that if people had reactions or were out of work for a couple of days with the first dose, they may not have come back, or just accessibility and ability to needing to be reminded or to get to that second dose. So we are looking at that data closely as well.
Thank you.
Dr. Cotton.
Hi, Camille Cotton. I just wanted to say that I am very comfortable with the data that's been presented. All of what we do in medicine involves weighing risks with benefits, and I am quite comfortable with the overall significant level of benefit provided with, in general, relatively low risk. I think the data will be very helpful for clinicians to help patients and families decide the best approaches to vaccination for individuals moving forward. So I'm very appreciative of that. I am quite concerned about the looming surge across the country, and I think now more than ever is really the time to continue vaccination. I am especially worried about immunocompromised hosts because that's the area I work in, and now is the time to both vaccinate to protect ourselves, but vaccinate to protect those that we love, those that we live with, and really do the right thing by ourselves, our communities, and our country. So thank you very much for the excellent data provided by those that have spoken today.
Thank you for your comments. Are there any other voting members that wish to make a comment before I open to the liaison and ex officios? I'm not seeing any hands. Liaison members, if you wish to make a comment, please. Dr. Goldman, please.
Thank you, sir. Well, first, as always, excellent presentation. And a comment and a question, just from an on-the-ground, real-world perspective, many of my patients are coming in specifically asking for the single-dose vaccine for many reasons: convenience, ease of access, not having to come back for a second dose. They can't get away from work to get 2 doses, and any number of reasons. So I don't want to minimize the risk or discount that there are some increased risk with everything we do, but as has been stated before, we really want to focus on the individual's choice and give the patients the ability to choose and allow them to have the access to all the vaccines and let them decide for themselves. So I think from a risk-benefit perspective, we're still preventing disease. It's more important to get the vaccines out there and to make sure everyone does get vaccinated, especially when we look at the issue of boosters that may not even work in the immunocompromised. We need to get everyone else vaccinated to make sure we protect those who are most vulnerable. So I think the data is quite compelling to make sure that we get everyone vaccinated, and patients do want the vaccine. I think it is good for access to care. With my question, though, in regards to the decreased uptake of the J&J vaccine after the last pause, was the study looked at, or the polling looked at, to see if that was specifically for the vaccine, or was it consistent with the decreased vaccine uptake across all vaccines and vaccine hesitancy?
Yeah, thank you for that question. So the way they asked the survey question is that, among people who had not yet received a vaccine, but who said they intended to receive one, they asked, which vaccines would you be willing to take? So this was really about people's, people who would, who still want to get vaccinated, who still need to get vaccinated, and what vaccine would they want to take? So that was the question that they asked. So that kind of 26%, that's 26% of people who hadn't yet gotten a vaccine but wanted a vaccine said they would be willing to take Janssen vaccine.
Thank you. Any other comments or questions? Opening it up to everyone. Any comments at all about anything that was presented during the course of this afternoon's presentations? Not seeing any. All right. Very good. Then we'll take a break at this point, and let's see here. We'll make it a 20-minute break and come back in 20 minutes. So at 20 till the hour. Thank you.